morning, everyone. Welcome to Department of Medicine Grand Rounds. I, along with Dr. Williams, our chair, am excited to present our speaker this morning. I'm Jennifer Cook, Vice Chair for Faculty Affairs and Education. And each year we invite our neurology colleagues at U of L to come and educate us. I think we all know that separating medicine and neurology is an artificial separation, and we're really sort of all one specialty together with different levels of expertise. And so we're really glad to have you here. This is Dr. Michael Haboubi. Dr. Haboubi is a U of L alum. He completed his neurology residency here at U of L in 2013, joined our faculty straight from residency, and he's served in a variety of positions. This includes Director of Neurology at Jewish Hospital, Director of the Neurohospitalist Program at U of L Hospital, as well as a long stint as the Neurology Clerkship Director. He's been recognized with awards for both excellence in teaching and humanism, and he currently sits on the American Academy of Neurology Subcommittee for Guidelines Development, Dissemination, and Implementation, which makes him the perfect person to present a clinical update on stroke for us today. Thank you and welcome.
Thank you so much. And just a quick addendum. I actually finished my 6 years with the what they abbreviate as the JEDI, the guideline dissemination. Nice. And so my 6 years there unfortunately are finished, but I still stay in contact with some of my good friends that are still on the committee.
Wonderful.
But thank you so much for having me. And there has been a lot of advancements in stroke care over the last few years, and this year in particular, 2023, I should say, it was very bountiful in the research that was coming out on large vessel occlusions, and I wanted to talk a little bit about that, although I think it's going to take the stroke community a few years to really sift through all the data and really make heads and tails of what this is telling us. So our objectives today, what is a stroke? How does it affect our community? How do we recognize a large vessel occlusion? What advancements have been made in treating these large vessel occlusions? And then another topic that's really close and dear to my heart is should we close PFOs? And I did the neurology grand rounds, neuroscience grand rounds a couple of months ago with one of my friends, Dr. Rahman, and with cardiology, and this is an area that we've been working on here at U of L. Let me minimize this here. Okay, so I have no relevant financial disclosures. I think if you were to ask everyone, what is a stroke? A lot of my patients can say they know what a stroke is, but then you ask them, well, what really is it? Can you define it? And a lot of them will have trouble with that. A lot of neurologists have trouble with defining it. If you have someone who has cardiac arrest and they hypoperfuse the brain, we know there's significant damage there, but is that a stroke? So the Stroke Council of the American Heart Association and the American Stroke Association define it as a central nervous system infarction, defined as brain, spinal cord, or retinal cell death attributable to ischemia based on neuropathological, neuroimaging, and/or clinical evidence of permanent injury. And it also broadly includes intracerebral hemorrhage and subarachnoid hemorrhage. So that's a mouthful. But in the US, there's almost 800,000 strokes per year, the majority of which are first-time strokes, and the vast majority of which are ischemic strokes, as opposed to the hemorrhagic strokes. On top of that, there's another 250,000 to 500,000 TIAs per year. And I often say that TIAs are one of the most over and underdiagnosed conditions that we see. Underdiagnosed because people have an episode, they decide they're going to wait it out at home, it gets better, and they never come in and seek help for it. And it's overdiagnosed because something happens. We have trouble defining exactly what it was. And we say, well, it might have been a TIA. And so I think that that number is rightfully broad. It could be over and underdiagnosed. It's a leading cause of disability. More than half of survivors over the age of 65 have reduced mobility. And of course, that's a big issue when it comes to other health factors as well. This next number here, the cost to the US, they estimated it being over $56 billion between 2018 and 2019. I've seen some studies that say it's over $100 billion, and that's both in direct cost of treating it in the hospital as well as the indirect cost of productivity in the workforce, time off for rehabilitation, and continuing disability afterwards. And then it is the number 5 cause of mortality. It was number 3 back when I started my residency, but we have done a better job of getting the word out in the community and to help better treatments. So it's now number 5 and maybe number 6, depending on how bad COVID is in a given year. Stroke is, we're in the stroke belt. And if you allow me to get up on my soapbox here, the amount of stroke mortality is correlated with inequities in health in terms of access to primary care, and being able to help identify and treat risk factors before it becomes a problem. And so that's certainly a big issue that we deal with in Kentucky. And it's expressed in part with the numbers that we see here, this graph that we see here. Stroke mortality has been decreasing pretty consistently since the 1970s. And the main reason for that is access to antihypertensive medications has made a tremendous difference and impact on stroke mortality. And it has been decreasing up until about the last 5 years. And now we've seen this rather slight uptick. And we'll talk about some of the reasons for that coming up here, because this is going back even before COVID. We do see that uptick beginning there. And that's in all regions of the country as well. So how do we recognize a stroke? Well, we use the NIH stroke scale to really help guide us. It is obviously not the be-all, end-all. And you may notice that on here it says a score of 0 is no stroke, and we know that's not true. Score of 1 to 4 is a minor stroke. Well, if it was you, I don't think you would say that that deficit is minor. Now you can't move your leg or can't walk as well as you used to. I would say that's pretty significant. But it does give us a way to have the same language when we're dealing with EMT, nurses, and other physicians to say, okay, comparing apples to apples, has their score gotten better? Has it gotten worse? And in what domains has it changed? And that can be very helpful for us. So it overgrades aphasia as well. So if you can see if you can't get words out, your ability to perform tasks may be okay, but your ability to answer questions may not be. If you're globally aphasic and you can't understand what the person is asking you to do, then you're going to have a much higher stroke scale score. And minor weakness, as I mentioned, is undergraded. If you're a world-class, pianist, and now you've had a stroke that only affects your right hand mildly, but it takes you from being this world-class virtuoso down to someone who's still better than me, but not able to perform your craft for a living. That's still a very significant event. And so we have given TPA to someone whose stroke scale score is 0, but their deficits are to them disabling. We use the BFAST acronym to help us recognize a stroke. On Jeopardy a couple of months ago, Ken Jennings had the acronym of FAST, and that was great. I'm glad he was helping to get the word out there. But we have updated it, and so I'll need to talk to Ken and let him know it's BFAST now. So B, balance trouble, and this, of course, is sudden balance trouble. E, eye problems. So blurry vision is not by itself a stroke symptom, but a lot of times patients will have some double vision and they will describe it as being blurry vision. And so if someone says blurry vision, we certainly consider that a possible symptom, although technically we're going to be looking for visual field cuts, we're going to be looking for double vision, we're going to be looking for loss of vision in one eye. Something like that would be more consistent with stroke. But of course, what patients say is not the textbook, what we're in tune to be listening for. So we have to keep an open mind. Sudden face drooping, sudden arm weakness, sudden speech trouble, and that includes dysarthria. Although if someone just has dysarthria, I'm usually thinking that it might be something else. Usually it's going to be dysarthria and either arm trouble or facial droop or something like that. And then the T is time to call 911. So that's the acronym that we were using for that. And then commonly confused terms or ideas. Aphasia is very hard for a lot of people, even in the medical field. How do you tell the difference between someone who's aphasic versus someone who is encephalopathic? How do you tell if they're aphasic versus really severe dysarthria? We've all had patients where they're so dysarthric, I can't tell if they are saying actual words. So that can be very tricky. Weakness versus ataxia. So on the stroke scale, we are gauging, is there trouble with coordination greater than the weakness that they have? And I think the simple test for all of us to try is to go pick up a 20-pound weight and then try to touch your nose and touch someone else's finger while you're holding that weight. It's much more challenging than we would think it would be. And a lot of times people will call me, especially in the emergency room, and they'll talk about tongue deviation. And very rarely is tongue deviation going to be a stroke symptom. If they have a brainstem stroke, absolutely that can be a concern, especially if it's a medial medullary stroke. But a lot of times when they tell me that they're having tongue deviation, it's more that they've got dentures or something else that's not fitting well, or they've got bubble gum in their mouth, and so it's more of a positioning issue. So when we are talking about stroke etiologies, this is extremely important. I always say stroke is not just a diagnosis, it's also a symptom. Something happened to cause that stroke. And so we use in adults, kids are a completely different story. We're not going to talk about them today. But in adults, we use the trial of org 10,172 in acute stroke treatment, so the TOAST classification, and we break it down into 5 categories. And depending on your patient population, these numbers can shift. In Japan, for instance, the magenta there, the undetermined etiology, is essentially 0. And why that is, I really don't have a great answer for if they are more forced to enter one of the other categories, or if it really is more clear cut. but it really is divided pretty evenly between undetermined etiology, cardioembolic, large vessel atherosclerosis, and then small vessel disease, with a sprinkling in of this other determined etiology if someone is hypercoagulable from cancer, or if they have a carotid dissection from a motor vehicle accident, then that can be there. We know the cause in that situation. And it'll fit into that category there. So if you know the etiology, your chances of preventing a second stroke is going to be much improved. And so, and it's also another way around. If you have a patient who you know has a cardiac thrombus, a left ventricular thrombus, then you should be prepared that they may have a stroke. And so if they have a change in mental status, having a very low threshold for calling a code stroke, or for having maybe more frequent neuro checks, can be really helpful. And I'm sorry, I don't have an attribution to this. I got these numbers from my friend Dr. Remmel, but it's what we know is that the greatest risk factor that we can control is hypertension. The greatest risk factor for stroke is actually age, but we don't have a cure for that. If anyone knows a cure, please let me know. But hypertension is the one that we can most control and can help prevent the most strokes with. So now shifting from all strokes to these large vessel occlusions. And at U of L, we use the CSTAT, which is the Cincinnati Stroke Triage Assessment Tool. We've been working extensively with the paramedics to identify and do a CSTAT, so that if it's positive, they know they need to skip a primary stroke center and come to a comprehensive stroke center, whether it's us or one of our colleagues over at Norton or Baptist. They should be brought to a comprehensive center in case this is a large vessel occlusion. We'll talk about thrombectomies here for quite a bit. If the score is greater than or equal to 2, there is an increased suspicion of large vessel occlusion. And the initial trial said that this was 71% sensitive, 67% specific. I think in our practice, what we have seen since then is that it's more sensitive than the 71%, but it's not 2/3 specific. Certainly, if you have someone who is having a seizure, they could very well have a gaze deviation, and there's your 2 points right there. And there's not a stroke; it's a seizure. So I think that we want to make sure we're not missing any large vessel occlusions, because that can be devastating. So we want to have as high sensitivity as possible. And if we overcall some things, that's okay. Other identifying features are cortical signs. So aphasia, gaze deviation. We talked about that a little bit already. The cortical sensory loss. So there's 3 cortical sensory signs. That's the agraphesthesia. When you write a number or letter in the person's hand, can they identify what is being written there? The dual sensory stimulation. Can they feel when they're being touched on 2 different areas at the same time? And then the last is stereoagnosia. When you put an object in their hand, can they identify that, yes, this is a bottle of Gatorade? Maybe they wouldn't be able to tell Gatorade, but a bottle of some sort when something is placed in their hand. Visual field deficits. Is there and so this is not the visual pathway goes through a lot of areas. That's not 100% specific for a large vessel issue. It could be a thalamic issue. It could be other areas as well. But certainly it does raise the alarm flag. And then, of course, is there neglect? Most commonly left side, but occasionally can be right side neglect as well. It's important to just also mention that dysarthria is not, so again, this is where that dysarthria versus aphasia is so important, especially in the emergency room. If they call me and say they're having language trouble, I need to know, is that aphasia? Are we going a large vessel occlusion pathway? Or if it's dysarthria, that can be a whole lot of different possibilities. So why are ELVOs so important? Well, typically they're going to have a much higher stroke scale score. I always remember back to when Dr. Abou-Shebel was here, and I was a resident, and I called him up with a patient, and he's like, well, this doesn't make sense. You know, you're telling me that they've got a really high NIH stroke scale score, but there's no cortical signs. Go back and reevaluate the patient. And so it was a good learning opportunity to really piece that together. In a large vessel occlusion, the average neurons lost per minute is 1.9 million. I need every neuron I have. So time is brain, and that is especially true in large vessel occlusions. And also, elbows don't respond as well to TPA as small vessel strokes. We will see elbows spontaneously recanalize. We will see elbows recanalize with TPA, or even more so with tenecteplase. And I have a feeling that the talk next year is going to talk about tenecteplase and how we might be shifting towards that instead of alteplase. But the way it was described to me is if you are trying to break down a boulder with a little squirt gun. TPA is that squirt gun, and it just does not do a great job on the boulders as it does on the smaller vessel strokes. But we usually still try. You know, a lot of times if someone comes in, they're in the window, we will give them the TPA, and then we will go for the mechanical thrombectomy if they're a candidate. So there has been a resurgence in mechanical thrombectomies over the last 10 years. The initial trials were a little bit underwhelming, but then the Mr. Clean trial out of the Netherlands set the world on fire. It showed that if done properly, the mechanical thrombectomies were superior to a lot of these other treatments that we have been trying. I think the number needed to treat for it's been a while since I looked at the original data for that, but I think the number needed to treat was about 6. And then when we looked at some of the other trials that came out around that time, the Dawn trial and the Diffuse 3 said, okay, we're not just looking at large vessel occlusions up to 6 hours now, we're looking at it up to 24 hours and having a good looking CT scan, specifically something called the aspect score, which looks at different areas of the CT scan to see if they are already showing signs of ischemia. And if they are, you lose a point. So a 10 is a perfect aspect score. A 0 is the worst that you could have. And so a lot of these trials are going to be looking at an aspect score of 6 or greater to say, okay, they are a good candidate for this procedure. So other things that we look at can be a CT perfusion scan, and on the left, the area in purple, that's looking at the core. Those are the areas of the brain that are dead and not coming back. And the areas in green is the area where there is decreased flow. And so we hypothesize if we don't do anything, then the area in green will all become purple and will all become core. So what we are looking for, and what the initially we're looking for with some of these trials here is there a small area of purple and a large area of green? And those are the patients that you can make the most difference in. And so we wanted a mismatch ratio of 1.8 or greater. We were looking for a core volume. Some studies said less than 50 milliliters. Some said less than 70, but greater than that was considered a large volume, a large core stroke, and those would not be a candidate initially due to the risk of bleeding. That was the main concern. You open up the vessel, you're recanalizing it, the risk of bleeding is going to be significant, this reperfusion injury. And so initially, that's what we were looking for. Small purple, large green, large mismatch volume, and then those were the people that we would take to the lab. So people started asking the question, well, what about the patients with a large core? Can we help them? And there have been 6 studies that have come out in the last year or are going to come out this year. Let's say last year and a half, or coming out this year. And we'll talk about some of them here. So one of the things that I felt we should talk about first, very briefly, is the modified Rankin score. That's what a lot of these studies are going to be using to grade how people are doing. And typically in the stroke world, we like to know, how is someone doing at 3 months? If their modified Rankin is between 0 and 2 or 0 and 3, we typically consider that to be good neurologic recovery. They're able to do things for themselves. 0 to 2, I think, is really important. Those are people that can live by themselves. 0 to 3, they might require some help intermittently. So then you get down to the modified Rankin of a 4. Now they're unable to walk. They need some assistance for their ADLs. Modified Rankin of 5, severely disabled, bedridden, incontinent, require full-time nursing care. And then 6 is deceased. And so they have taken a lot of surveys of people to say, would you rather be dead, or would you rather have a modified Rankin of 5? And most people, not all, of course, this is a very personal decision, but most people would say they would rather not be a 5. And so if there is a procedure that can increase their chances to have a good neurologic recovery, but maybe has an increased risk of death that goes with it, most people would take that. And so there has been a really strong push in the interventional stroke world to try and avoid the modified Rankin of 5. Sometimes, despite our best efforts, we're going to have patients that end up there, of course. But I think it is important when you're talking to patients and their families to say, there is a procedure that maybe has increased risk more than what we typically would say, but there is a potential benefit that goes with it as well. It's important to try and relay all of this information to the patients and their families so they know what exactly they're going in for. So the first of these 6 studies that came out was the Rescue Japan Limit study. That came out in 2022. It was a randomized open-label multi-center study in Japan, and that was looking at aspect scores between 3 and 5. So there already is significant CT changes, and it involves a pretty significant amount of the brain tissue. And they're looking for within 6 hours of the last known well, or 24 hours if there are no flare changes on the MRI. So we typically think that it takes about 6 hours for strokes to show up on a flare, which is the fluid attenuated inversion recovery image. And so the right away, the DWI, the diffusion weighted imaging, and the ADC, the apparent diffusion coefficient, those are going to change right away. As soon as there's any sign of ischemia, we'll see changes there. So if it's less than 6 hours, or we think it's less than 6 hours based on imaging, they were eligible in this trial out of Japan. They looked at 101 patients with the endovascular therapy, that's the ET, versus medical therapy. So the endovascular and endovascular and medical therapies combined versus medical therapy alone. And they looked at the modified Rankin at 90 days. And this is the neat little graph that we like to look at to say, how did their modified Rankin end up? And so in the group that got the endovascular therapy as well, they had better results in terms of modified Rankin of 0, modified Rankin of 1, 0 to 1, 0 to 2, 0 to 3, and significantly for 0 to 4 here as well. And much fewer patients in the 5 and fewer patients in the 6, although this is, again, a relatively small sample size here. So the next trial was the SELECT-2, and that came out last year, and that was a prospective randomized open label trial looking again at ICA, or the first segment of the MCA occlusion, less than 24 hours from onset. They were looking for aspect of 3 to 5 or a core of 50 milliliters on a perfusion study. And again, looking at endovascular therapy plus medical therapy versus medical therapy alone, and looking at modified Rankin at 90 days. Again, we're seeing that much fewer people in the modified Rankin 5, fewer people in the modified Rankin 6 level as well. Much more people in the 0 to 4, much more people in the 0 to 3. And when you look at the 0 to 2 as well, again, these are the people that are living independently, significant changes there as well. So very encouraging on this. The tension trial also came out last year, and this was another prospective multi-center open label randomized trial, aspects score of 3 to 5. This was looking at up to 12 hours from onset, and again, looking at the modified Rankin at 90 days, similar as what we've seen before. And it's always nice when you have all of these different studies being done in different parts of the world, all of them showing the same sort of results. That tells us that it's something that it does translate nicely between populations. The angel aspect was also from last year. This was a trial in China, looking at, again, anterior circulation, large vessel occlusions, aspect score 3 to 5, or a core of 70 to 100 milliliters. And it was within 24 hours from the last known well. And this one, there was a slight increase in the number of people who had a modified Rankin of 6, but much less again in the 5, and the number of people that were 0 to 3, much better in the endovascular therapy group than in the medical management group. So now they're looking at the LASTE study. I don't know how that's pronounced. The results are possibly coming out tomorrow. That's what I've been hearing through the grapevine. But they're looking at results that are going to be, or looking at aspect scores from 0 to 5. So before it's really been the 3 to 5, but now they're saying, what about the worst of the worst, the 0 to 5? Are they going to benefit as well, especially that group that's the aspect of 0, 1, or 2? And they're looking at less than 7 hours from onset. So there are still going to be other controversies. What about posterior circulation, large vessel occlusions? You know, if someone has a basilar occlusion without treatment, that has a 90% mortality rate. So typically we bring those patients to the lab, you know, regardless. If they already have significant damage to the posterior circulation, do they benefit? We really don't have an answer for that. We just know if we don't do anything, they're going to most likely have a very poor outcome. Resource management, you know, with these large vessel cores, if you have a shortage of providers, interventionalists, how do you decide, you know, who is going to be a candidate? Do you only pick the best, the most likely people to have a good result? Or do you say, you know, at what point do you say, well, this is futile? What about time limits? You know, a lot of these things are looking at less than 24 hours or less than 6 hours. What if we have someone who was found down and their last known well was 2 days ago? And we know they've got a large vessel occlusion. It's a large core. Would they benefit from a thrombectomy? And then also, does experience matter? If you have a provider who is, you know, fresh out of fellowship, and they've maybe not done a ton in their fellowship, but, you know, it was a lower volume center. You know, how do their results compare to someone who is doing this on a regular basis? And should patients have a say in, like, nope, this is your first time doing a procedure like this? I would rather have it be someone else. Certainly good ethical questions. And I might be dating myself with this, but in the words of Monty Python, now for something completely different. So coming back to the TOAST criteria, if as we have people get older, the amount of how that, you know, that pie chart that I showed you earlier, how that changes is going to be played out here. So, and part of that we're going to see is that AFib is very uncommon in a 20-year-old, but pretty common in someone in their 80s. And I might sneeze here. Hold on 1 second. I think I jinxed it, so we're okay. So when we look at this chart here, this is very busy, but what it's showing us is that younger people are having strokes that before were only really seen by older people. And that, you know, the number of these small vessel risk factors, you know, younger people with high blood pressure, younger people with diabetes, younger people with obesity, are with high cholesterol. They're all being increased pretty significantly. And so now when we are seeing someone who, and in the stroke world, you know, a young person with a stroke is either someone less than 50 or someone less than 40. Different studies will look at different ages. As someone who's now in their 40s, I like the idea of under 50 being young, and that will change as I get closer to 50 as well. I'll say, 60 is young. But what we were seeing is that there are more risk factors. More young people are having more and more risk factors. And so that is changing the that pie chart that we were seeing before as well. We also describe something called ESIS, this embolic stroke of unknown source, where we say this looks embolic, but we haven't proven it. And different countries will have different rates of ESIS. As I mentioned, Japan has very few. So there was a young ESIS longitudinal cohort from last year that showed that the annual rate of recurrent stroke was 1.9%. And that when they did have another stroke, it also looked embolic. So that's at least pointing us in the direction of, hey, something cardioembolic is likely the cause for these patients. And when they looked at the presence and the prevalence of PFOs in these patients, they were greater than the general population. And the patients who had a PFO and had ESIS had less hypertension, less diabetes, less hyperlipidemia, and a lower BMI. And so that is pointing us in a direction and say, hey, maybe this PFO is important. So they have there are 18,000 patients, 18 to 60 in the US with a PFO and a cryptogenic stroke. And the PFOs are the most common right to left shunts, and about a quarter of all adults have a PFO that's persistent. And the mean diameter of these PFOs is just under 5 millimeters, and that is sufficient to cause emboli large enough to occlude the middle cerebral artery, which is about 3 millimeters, and major cortical branches, which are about 1 millimeter. And so these are some of the pictures that I've borrowed from Dr. Rahman with his permission. But we see here what, I'm not sure if you guys can see my mouse, but what a normal atrial septum would look like. And here is an agitated saline study that shows the right to left shunt and how a blood clot could pass through that PFO and become a paradoxical embolus. So the big question is it the PFO's fault? And there are 5 features of a PFO that increase the risk that it is coming from the stroke is coming from this. And so the first is going to be presence or disposition to venous thrombosis. So strongly increased risk when there is a concurrent DVT within 48 to 72 hours after stroke onset. So typically what we'll do is we will order an echo on pretty much every patient who has a stroke. And if we see that there is a PFO on that, we will order a lower extremity Doppler. Unfortunately, the most likely area for clots to appear is going to be in the thigh, and the most likely area for the Doppler to be assessing is the calf. So we do have an area where it's a little bit, it is possible that we are missing some. Venous hypercoagulable states also increase the likelihood that PFO is causally related. And so things like protein CNS deficiency, typically thought to be venous in adults, but have been shown to cause arterial thrombi in children. The factor V Leiden mutation is strongly linked to venous thrombosis. The prothrombin gene mutation can cause both arterial and venous thromboses. Antiphospholipid syndrome is, 30% can be arterial, but that doesn't mean that you can't have some venous causes of that as well. And then the hyperhomocystinemia can cause both arterial and venous thrombosis as well. So there is if there is an increased right to left shunt flow, and the greater the volume of the flow across the PFO, the greater the chance that a venous thromboembolism will swerve across the shunt. So the cardiologists are always very good at detailing the size and also where does this shunt take place? Is it only with Valsalva, or is it with respirations, gentle respirations, or just is it a pretty wide open shunt? Um, Incidentally, I had a patient just recently who, um, wonderful woman and wonderful family, and they were telling me that it's really weird that this happened right as she was lifting all these heavy pieces of wood up the stairs. And um, I was like, they said that's just really, it was really strange. She was just lifting this heavy wood, really straining with it, and then she had her stroke. And sure enough, she had a PFO, and we felt that it was likely the cause. Um, is there an atrial septal aneurysm? So this helps with the access to the PFO, and uh, we, and I think about this in a slide coming up here in a second, but if there's just an atrial septal aneurysm by itself, that's not going to be a good indication for closing if there is no stroke. But if you have a stroke, it looks embolic, and you've got this PFO and you have an ASA, that does make it a little bit more likely that this could be the trigger. And then, of course, is there an embolic looking stroke? If we see that the patient has a pontine stroke and has a lot of white matter changes, and they've got uncontrolled hypertension and hyperlipidemia, and all of this is looking, small vessel disease, then less likely that it's going to be the PFO. And then also absence of risk factors for atherosclerosis. One of the things that I found really interesting, one of my really bright young residents came up to me earlier this year and was saying, hey, this study here says that you're at an increased risk of stroke if you have a PFO that is asymptomatic. Why is that? And so it's able to work that through with them to say, well, if the PFO is asymptomatic, what are they more likely to have? They're more likely to have hypertension. They're more likely to have hyperlipidemia, diabetes. They're more likely to be a smoker. They're more likely to be older. And they have all these other risk factors that are going to be more likely to cause a stroke. So PFO causing a stroke is relatively rare compared to these other risk factors, but it's not one we want to ignore. So there have been 3 updates from 2020 to 2022 in terms of guidelines for how do you treat PFOs. And so the strength of the recommendation for closure has been increasing over time. So initially the AAN said in 2020 that it's possibly effective, ineffective, or harmful for the given condition in the specified population. And then in 2021, they were giving a moderate 2A recommendation for 18 to 60 with a non-lacunar ischemic stroke. So again, embolic looking, that has no known cause and high-risk anatomic features. It's reasonable to go with closure. And then 2022, now they're saying that in patients 18 to 60 with a prior PFO-associated stroke, they recommend closure rather than antiplatelet therapy alone, independent of patient anatomy. So why some of these changes? So first of all, another just slide here saying the number needed to treat to prevent 1 stroke 29 for PFO closure at 5 years. And so that's it puts us in between. So if we go to the carotid endarterectomy patients, if it's a symptomatic carotid that you have the surgery for, number needed to treat in 5 years to prevent one stroke is 6. If it's asymptomatic, depending on the study you're looking at, again, also that's for 70 to 99% for the symptomatic. Same thing for the asymptomatic. The number needed to treat to prevent one stroke in 5 years can be anywhere from 34 to 53, depending on the study you look at. So this is in between there, and certainly can be helpful. So I was on the guideline committee back in 20. I think my term ended in 2018, and that was right when some of these studies were coming out that were changing the data. And this paper here with Doctors Messe and Gronseth, Dr. Gronseth is fantastic. He's one of the smartest people I've ever met. And he just lives and breathes data and how to manipulate it into something that is actionable for neurologists. And so there was new data from the RESPECT trial that showed that recurrent stroke occurred in 28 participants randomized to medical therapy, and 18 assigned to closure, and that had a rate difference of minus 0.47, as it says there. And the reduced trial came out, that was 664 participants. And so what they did was they were able to say all of these studies by themselves are not strong enough. They had the closed trial to defense PFO. All these trials were not strong enough on their own to power a meaningful conclusion. But when they did a meta-analysis with all of them, that was powerful enough to show that there is benefit to closure in these particular patients. So their practice update says patients who have a PFO after stroke should be considered for PFO closure after appropriate evaluation by both a stroke neurologist and cardiologist, and be advised about its risks and benefits. And so that was the impetus for the heart-brain team here at U of L. So we helped to form the PFO closure board. It formed in 2022. We meet monthly to discuss all patients under consideration for PFO closure. Most patients are going to be assessed and then told, no, it's most likely due to something else. And that's fine. We want to make sure that we're at least assessing them and seeing what their risks are. So this is kind of how a stroke workup at U of L proceeds. After our standard workup with imaging and CT and MRI and echo, do we have a cause? And if we don't have a cause, then we have to do, okay, well, is there a PFO? If there is, then we're going to do some extended cardiac monitoring, either with a loop recorder or with some of these other devices that we have out now. And so in the guidelines, it doesn't say how long you're supposed to monitor for. It just says a good extended cardiac monitoring. So we typically recommend 30 days. That's what we have jointly decided on. And so we typically will do a loop recorder if they're an inpatient. And that way, when they follow up with us as an outpatient, we can say, has AFib been detected? And if it's not, and they're still cryptogenic, then we look at the ROPE score. And that's the risk of paradoxical emboli. And you can go on MD Calc and you can calculate the rope score for your patient as well. And we do know that if the rope score is greater than 6, they are likely to benefit after this type of workup here. If it's less than 6, it still may be worthwhile in having it closed. But we want to make sure that we're ruling out everything else first, of course, as well. So just to summarize, so why do some of these, what are these high risk features? And as I just mentioned here, the greater the rope score, the more likely it is that the PFO is the cause. And also the less likely they are to have a recurrent stroke because they're less likely to have high blood pressure, less likely to have diabetes. They're younger. And then we talked about the atrial septal aneurysms here. We're running up on time here, so I'm just going to move forward here. So after the PFO is closed, there is a rare but documented risk of atrial fibrillation developing. They are really in the first 45 days. They are not thought to be the cause of the index stroke. So we feel that this is something that is some irritation on the heart from the procedure, and that is typically benign, but something we just want patients to be aware of. It's performed under conscious sedation, and it's a same-day procedure. Typically takes less than an hour, and Dr. Rahman can tell you a lot more about this than I can. So how do you contact the PFO closure board? You can either call my office, you can call Dr. Rahman's office, you can consult either of us while the patient's in the hospital, and we can at least get the workup started and go from there. So that's all I have. Thank you very much. And if there are any questions, I'd be glad to help answer them.
Great. Thank you so much, Dr. Haboubi. A lot of information for us to digest, and it looks like you have sparked some curiosity with one of our cardiology fellows. I don't know if you were able to view the chat, which might be helpful
Open that up
as
here.
we go through these questions. I can read the first one. So, do we routinely conduct a CT head perfusion study for all stroke patients? Furthermore, is CT head perfusion utilized in decision-making to determine the eligibility for mechanical thrombectomy in patients outside the time window for TPA administration?
Yes, great question. So for the short answer is no, we don't use CT perfusion on everyone. We are most of our stroke providers will use it for patients that are greater than 6 hours from onset and have an elbow to help assess the size of the core. But if it is less than 6 hours, there have actually been some documents of ghost strokes where it makes it in some areas look larger than they actually are. And so if it's less than 6 hours and they have an elbow, typically we will just take them straight to the lab. If someone is in terms of administering TPA, we have been looking at that ever since I have been a resident here. To say, can we use CT perfusion for TPA administration? And the answer is really no, unfortunately. And we don't have a great explanation for why. It would be nice if if I mean, logically, it should be the same. But I think that that's, maybe part of the reason why we're seeing with the data for the large core that they're still having some benefit, is that the CT perfusion, again, is just giving us um, an estimate of what's going on. It's a tool, and you shouldn't be relying completely on this because it's not actually looking at the brain tissue.
Great, thank you. Let's hop over to a raised hand and then we'll come back to chat questions. So Dr. Stoddard, is that you?
That's right. Thank you. Hey, Michael. Listen, I was very interested in your talk. Thank you very much for a spectacular presentation. One of the things I would point out here is the technical difficulty in terms of diagnosis of PFO. One of the things that occurs is intropulmonary shunting, and this can occur in normal people, and it's more frequent in cryptogenic stroke patients. So often when you have a diagnosis of a PFO, it can be actually wrong. So I would just say that when you have your board meeting and review studies, just to put in that perspective that everything that looks like a PFO is not, particularly on transthoracic echo, differentiating that from intropulmonary shunt is a nightmare, and TE really helps to simplify it, but also even in that setting, it can be difficult. And we did find that cryptogenic strokes in those patient populations had a much higher frequency of intropulmonary shunting. And I'm not talking about cirrhosis or things that are pathological. These are circuits that occur in normal people. Some have just more robust physiology that leads to this right to left shunting. And you would not think theoretically that closing a PFO or attempting to close something that's not a PFO would be beneficial in that patient population. So that's one comment. And my last question to you, though, is what about PFO closure in patients with migraines? So just a different topic. Thank you.
Yeah, and I certainly appreciate, we have benefited greatly from your expertise over the years, and I really appreciate all that you've done for our patients. The PFO closure in migraines is a very good topic that I will say Dr. Soul is probably a better person to talk to regarding that. We do know that there is an increased risk of migraine in patients with PFO, but I am not aware of the latest data on if closing the PFO helps with their migraine or not. The studies I remember from when I was younger was that it did not help. There was maybe a trend towards helping, but it never reached statistical significance. And so if there has been a more recent update on that, I would have to talk with our headache expert.
Great, thank
Thank
you.
you.
We'll try to quickly answer the other two questions in the chat, even though we're out of time here for anybody who can stay. So regarding IV alteplase, the FDA had issued a label to administer it within 3 hours of ischemic stroke. Is there any data supporting an extension of this window to 4 to 4.5 hours, which is commonly practiced?
Yeah, so what we know is that, as we said, time is brain. If you give TPA within the first hour of stroke symptoms, it is magical. It works really well. If you give it within 2 hours, it's really good. If you give it within 2 to 3 hours, you're probably not really going to get much difference. There is a little bit of a difference that does help. And if you give it between 3 and 4.5 hours, it's safe. The number needed to treat is pretty high, but there is a little bit of benefit that you can get there. But really, the establishing reasonable outcomes, I usually let patients know this may not help a lot, but it has a chance to. And so we do typically will still give it within 3 to 4.5 hours.
Right. And then lastly, the Sampras wingspan stent trial. assessing the safety and efficacy of intracranial stents ended in controversy. Are there any ongoing trials in this particular field?
There are, typically I do not like it when my patients get intracranial stents. The data to this point is against it. I think there will be a point in the future where it will be recommended for certain patients. It's going to require the right equipment, the right patients, it's it's not routinely practiced right now, and I strongly encourage people, if they're recommended to have one, to get a second opinion if they can.
Excellent. All right. Okay, thank you for the questions. Dr. Haboubi, we really appreciate your time today. I think you've clarified a lot of clinical information for all of us in regards to stroke, and we appreciate everyone attending today as well. And I think that wraps up our grand rounds.